Welcome to this video entitled, Adrenal Disorders, Pathogenesis and Pharmacotherapy. The adrenal glands are small but powerful organs that sit just above the kidneys. They are located in the retroperitoneal space, meaning they lie behind the lining of the abdominal cavity. Each gland rests superior and slightly medial to its kidney, protected deep within the body. These glands are also enclosed within the fascia of Gerota, a supportive layer of connective tissue that helps anchor and protect the kidneys and adrenal glands. Even though the adrenal gland looks like one structure, it actually functions as two organs in one. It has an outer adrenal cortex and an inner adrenal medulla. Each part has a different origin, structure, and role in the body. Together, they help maintain balance during both normal daily activities and stressful situations. The adrenal medulla forms the inner core of the gland. It develops from neuroectoderm, the same embryologic tissue that gives rise to parts of the nervous system. Because of this origin, the medulla acts almost like a specialized sympathetic nerve center. It responds rapidly whenever the body faces stress, fear, excitement, or danger. The adrenal medulla secretes catecholamines, mainly epinephrine and norepinephrine. These hormones are commonly known as adrenaline and noradrenaline. They are released directly into the bloodstream during the fight or flight response. This sudden hormone release prepares the body to react quickly in stressful situations. Epinephrine increases heart rate and boosts blood flow to vital organs and muscles. It also raises blood glucose levels so the body has enough energy for immediate action. Norepinephrine mainly causes blood vessels to constrict, helping maintain blood pressure during stress or shock. Together, these catecholamines allow the body to respond rapidly to emergencies. They increase alertness, improve breathing, and sharpen physical performance. This is why a person may feel their heart racing, palms sweating, or muscles tightening during moments of fear or excitement. The adrenal glands may be small, but they play a massive role in survival and body regulation. Their unique structure allows them to combine endocrine and nervous system functions in one compact organ. Understanding adrenal anatomy is important because these glands influence blood pressure, metabolism, stress responses, and overall homeostasis every single day. The adrenal cortex is the outer part of the adrenal gland. It sits right above the kidneys and plays a huge role in keeping the body balanced. Interestingly, this structure develops from mesoderm during embryonic growth. The adrenal cortex is divided into three special layers, or zones. Each zone has its own hormones and unique job. A simple way to remember them is salt, sugar, and sex hormones. The outermost layer is called the zona glomerulosa. This zone produces mineralocorticoids, mainly aldosterone. Aldosterone helps the body control salt, water, and blood pressure. When blood pressure drops, the kidneys activate the renin-angiotensin-aldosterone system, also known as RAS. This system tells the zona glomerulosa to release more aldosterone. High potassium levels can also stimulate this zone directly. Aldosterone acts on the kidneys. It helps the body keep sodium and water while removing excess potassium. As a result, blood volume and blood pressure rise. The middle layer is the zona fasciculata, and it is the largest zone of the adrenal cortex. This layer produces glucocorticoids, especially cortisol. Cortisol is often called the stress hormone, but its job goes far beyond stress. Cortisol helps regulate metabolism, blood sugar, immune responses, and energy balance. During stressful situations, cortisol gives the body extra fuel and helps maintain stability. The release of cortisol is controlled by the hypothalamic-Pituitary-Adrenal axis, or HPA axis. The hypothalamus releases corticotropin-releasing hormone abbreviated as CRH, which stimulates the pituitary gland to release adrenocorticotropic hormone abbreviated as ACTH. Adrenocorticotropic hormone then signals the zona fasciculata to produce cortisol. The innermost layer is the zona reticularis. This zone produces adrenal androgens such as DHEA and androstenedione. These hormones are weaker than testosterone, but they are still very important. In peripheral tissues, these adrenal androgens can be converted into testosterone and estrogens. They contribute to puberty, body hair development, and overall hormonal balance. Together, the three zones of the adrenal cortex work like a coordinated team. One controls salt and blood pressure. Another manages stress and metabolism. The last supports sex hormone production. Even though these layers are tiny, their hormones influence nearly every system in the human body. Cushing's syndrome happens when the body is exposed to excessively high levels of glucocorticoids for a long period of time. The main glucocorticoid involved is cortisol, a hormone produced by the adrenal cortex. Normally, cortisol helps the body respond to stress, regulate blood sugar, and control metabolism. But when cortisol levels stay too high, the effects become harmful instead of helpful. People with Cushing's syndrome may develop weight gain, muscle weakness, thin skin, high blood pressure, and elevated blood sugar levels. Fat often accumulates around the face, neck, and abdomen, creating the classic moon face appearance. One major category is called adrenocorticotropic hormone-dependent Cushing's syndrome. This form accounts for about 80% of endogenous cases, meaning the excess cortisol is produced from inside the body rather than from medications. In adrenocorticotropic hormone-dependent disease, the problem begins with too much adrenocorticotropic hormone, or adrenocorticotropic hormone. Adrenocorticotropic hormone overstimulates the adrenal glands and pushes them to produce excessive cortisol. The most common cause is called Cushing's disease. Despite the similar name, Cushing's disease is actually a specific subtype of Cushing's syndrome. It occurs when a pituitary corticotroph adenoma secretes too much adrenocorticotropic hormone. The pituitary gland sits at the base of the brain and normally controls cortisol production very carefully. But in Cushing's disease, the adenoma ignores normal feedback signals and continues releasing adrenocorticotropic hormone non-stop. As adrenocorticotropic hormone rises, the adrenal cortex becomes overstimulated. Cortisol production increases dramatically, and the body enters a prolonged hypercortisolemic state. Another important cause is ectopic adrenocorticotropic hormone secretion. In this condition, adrenocorticotropic hormone is produced by tumors located outside the pituitary gland. A classic example is small cell lung cancer. Certain bronchial carcinoid tumors can also produce adrenocorticotropic hormone abnormally. These tumors act like hormone factories and continuously drive cortisol production. Because the adrenocorticotropic hormone comes from outside the pituitary, the adrenal glands remain highly stimulated even though cortisol levels are already very high. In rare situations, tumors may secrete corticotropin-releasing hormone instead of adrenocorticotropic hormone. Corticotropin-releasing hormone normally comes from the hypothalamus and stimulates the pituitary to release adrenocorticotropic hormone. When ectopic corticotropin-releasing hormone is produced, it indirectly causes excessive adrenocorticotropic hormone release from the pituitary, which then increases cortisol production from the adrenal glands. So, The key idea in adrenocorticotropic hormone-dependent Cushing's syndrome is persistent hormonal overstimulation. Too much adrenocorticotropic hormone leads to too much cortisol, and over time, nearly every organ system in the body feels the effects. Cushing's syndrome can also develop without excess corticotropin-releasing hormone stimulation. This form is called corticotropin-releasing hormone-independent Cushing's syndrome, and it accounts for about 20% of endogenous cases. In this condition, the adrenal glands produce cortisol on their own, even when corticotropin-releasing hormone levels are low. The problem starts directly inside the adrenal cortex itself. One common cause is a unilateral adrenal adenoma. This is a benign tumor that forms in one adrenal gland and begins secreting cortisol autonomously. Because cortisol levels rise so high, the pituitary gland responds by reducing corticotropin-releasing hormone production. But the adrenal tumor ignores the signal and keeps producing cortisol anyway. Adrenal carcinomas can also cause corticotropin-releasing hormone-independent Cushing's syndrome. Unlike adenomas, these tumors are malignant and often produce very large amounts of cortisol. Patients with adrenal carcinomas may develop symptoms rapidly. The condition can become severe because cortisol levels increase dramatically over a short period of time. Another important cause is bilateral macronodular adrenal hyperplasia, also called AIMAH. In this disorder, both adrenal glands become enlarged and filled with multiple nodules. These nodules gradually start producing cortisol independently of corticotropin-releasing hormone control. Over time, cortisol secretion becomes excessive and persistent. Primary pigmented nodular adrenal disease, or PPNAD, is another rare cause. This condition is strongly linked to Carney complex, a genetic syndrome involving multiple endocrine and non-endocrine tumors. In primary pigmented nodular adrenal disease, tiny pigmented nodules develop throughout the adrenal cortex. Even though the glands may appear small, they can still produce excessive cortisol. What makes corticotropin-releasing hormone-independent Cushing's syndrome unique is that the adrenal glands no longer rely on pituitary stimulation. The adrenal tissue becomes self-sufficient and continuously releases cortisol. However, the most common overall cause of Cushing's syndrome is not endogenous disease at all. It is actually iatrogenic Cushing's syndrome, caused by chronic use of exogenous glucocorticoid medications. These medications include drugs like prednisone, dexamethasone, and hydrocortisone. They are commonly prescribed to treat asthma, autoimmune diseases, allergies, and inflammatory conditions. When glucocorticoids are used for long periods or at high doses, they mimic the effects of excess cortisol in the body. Patients may develop central obesity, muscle wasting, fragile skin, osteoporosis, and high blood sugar levels. At the same time, the pituitary gland reduces corticotropin-releasing hormone secretion because it senses that cortisol levels are already high. This causes the normal adrenal glands to shrink from lack of stimulation. That is why long-term steroid therapy should never be stopped suddenly. The adrenal glands may need time to recover normal cortisol production. So, in corticotropin-releasing hormone-independent and iatrogenic Cushing's syndrome, the adrenal glands or external steroids bypass the normal hormonal control system, leading to chronic cortisol excess and widespread effects throughout the body. Cushing's syndrome is a condition caused by long-term exposure to excessive cortisol. Over time, high cortisol levels affect almost every organ system in the body. The physical changes can become very noticeable. One of the classic signs is centripetal obesity. This means fat accumulates mainly around the trunk and abdomen, while the arms and legs may remain relatively thin. The face also changes in appearance. Many patients develop rounded, moon faces, caused by fat deposition around the cheeks and jawline. Another hallmark feature is the buffalo hump, which refers to fat accumulation at the upper back and base of the neck. The face may also appear unusually red or flushed. This is called facial plethora and happens because cortisol affects blood vessels and skin circulation. The skin itself becomes fragile and thin. Even minor trauma can damage the skin easily. Patients often notice easy bruising because the supportive connective tissue beneath the skin becomes weak. Tiny blood vessels rupture more easily than normal. One of the most striking findings is the appearance of wide violaceous striae. These are purple stretch marks that commonly develop on the abdomen, thighs, breasts, or arms. Unlike ordinary stretch marks, these striae are usually broader and darker because cortisol weakens collagen fibers in the skin. Cushing's syndrome also causes major metabolic complications. High cortisol levels increase blood pressure, so hypertension is extremely common. Cortisol also raises blood glucose levels by increasing gluconeogenesis and reducing insulin sensitivity. Over time, many patients develop glucose intolerance or even full diabetes mellitus. The skeletal system is heavily affected too. Cortisol accelerates bone breakdown and reduces bone formation, leading to severe osteoporosis. As bones weaken, fractures can occur even after minimal injury. Vertebral compression fractures are especially common. Muscle tissue also suffers from prolonged cortisol excess. Patients frequently develop proximal muscle weakness, making activities like climbing stairs or standing from a chair more difficult. Hormonal imbalances may also appear. Increased androgen activity can cause hirsutism, especially in women, leading to excessive facial or body hair growth. The immune system becomes suppressed as well. Cortisol reduces inflammation and weakens immune responses, making infections more likely. Psychological symptoms are also important. Patients may experience mood swings, irritability, anxiety, depression, or difficulty concentrating. In severe cases, psychiatric disturbances such as psychosis can even develop. What makes Cushing's syndrome so significant is that the symptoms build gradually over time. The body slowly changes under constant cortisol exposure, affecting appearance, metabolism, bones, muscles, immunity, and mental health all at once. Medical therapy plays an important role in managing Cushing's syndrome, especially when surgery is delayed, unsuccessful, or not possible. These medications mainly work by reducing cortisol production inside the adrenal glands. Many patients receive drug therapy before surgery to stabilize blood pressure, blood sugar, and other complications caused by excess cortisol. In some cases, medications are the main long-term treatment option. One major group of drugs is called steroidogenesis inhibitors. These medications block the enzymes needed for cortisol synthesis. A commonly used drug is ketoconazole. Although it was originally developed as an antifungal medication, it can also suppress adrenal steroid production. Ketoconazole inhibits several cytochrome P450 enzymes involved in cortisol synthesis. Two important targets are 11-beta-hydroxylase and 17,20-lyess. By blocking these enzymes, ketoconazole reduces cortisol production and helps control the symptoms of hypercortisolism. Patients may experience improvements in blood pressure, blood sugar levels, and muscle weakness as cortisol levels decline. However, Ketoconazole must be monitored carefully because it can cause liver toxicity. Regular liver function testing is very important during treatment. Another key medication is metyrapone. This drug works more specifically by inhibiting the enzyme 11-beta-hydroxylase. This enzyme is essential for the final steps of cortisol synthesis in the adrenal cortex. When the enzyme is blocked, cortisol production drops rapidly. Metyrapone is often useful when quick biochemical control is needed. It may also be combined with other medications for stronger cortisol suppression. Because cortisol synthesis decreases, precursor hormones may accumulate and increase androgen production. Some patients may develop acne or hirsutism as a result. Mitotane is another important medication, especially in adrenal carcinoma. Unlike the other drugs, mitotane has direct adrenalytic effects. This means it can actually damage and destroy adrenal cortical cells while also reducing steroid hormone production. Mitotane acts slowly, but it can provide long-term suppression of cortisol secretion. Because it affects adrenal tissue directly, patients may eventually require glucocorticoid replacement therapy. In severe or life-threatening cases, rapid cortisol control becomes critical. This is where etomidate can be extremely useful. Etomidate is given intravenously and works quickly to suppress steroid synthesis. It is often used in hospitalized patients with acute severe hypercortisolism. For example, patients with severe infections, psychosis, or dangerously high blood pressure from Cushing's syndrome may need emergency cortisol reduction. Etomidate can rapidly lower cortisol levels while doctors stabilize the patient and prepare for definitive treatment. So, steroidogenesis inhibitors are powerful tools in Cushing's syndrome management. They target the adrenal hormone pathway directly and help reduce the harmful effects of chronic cortisol excess throughout the body. Not all medications for Cushing's syndrome work by reducing cortisol production. Some drugs work differently by blocking cortisol's effects on body tissues or by reducing adrenocorticotropic hormone release from the brain. One important medication is mifepristone, also known as Ru-486. This drug acts as a glucocorticoid receptor antagonist. Instead of lowering cortisol levels directly, mifepristone blocks cortisol from binding to its receptors inside cells. In simple terms, cortisol may still be present, but the body cannot respond to it normally. This approach can be very effective in controlling the metabolic complications of Cushing's syndrome. One major benefit is improvement in hyperglycemia. Many patients with Cushing's syndrome develop high blood sugar or diabetes mellitus because cortisol increases glucose production and reduces insulin sensitivity. By blocking cortisol's action, mifepristone can significantly improve blood glucose control and overall metabolism. Patients may also experience improvements in weight gain, fatigue, and other symptoms linked to cortisol excess. However, monitoring this medication can be challenging. Normally, doctors follow cortisol levels to guide treatment adjustments. But with mifepristone, cortisol levels often remain elevated because the drug blocks the receptor rather than reducing hormone production. This means there are no reliable biochemical markers to measure the exact treatment effect. Doctors must mainly rely on clinical improvement and careful observation of symptoms. Because of this, close follow-up is extremely important during therapy. Patients need monitoring for side effects such as low potassium levels, fluid retention, or adrenal insufficiency. Another treatment strategy focuses on reducing adrenocorticotropic hormone production at the pituitary level. These drugs are often called neuromodulators because they affect hormone signaling pathways in the brain. One important example is pasireotide, a somatostatin analog. Somatostatin is a natural hormone that inhibits secretion of several other hormones, including adrenocorticotropic hormone. Pasireotide binds to somatostatin receptors on pituitary corticotroph tumors and suppresses adrenocorticotropic hormone release. As adrenocorticotropic hormone levels fall, the adrenal glands receive less stimulation, and cortisol production decreases. This medication can be particularly useful in patients with Cushing's disease caused by pituitary adenomas. Another neuromodulator is cabergoline, a dopamine agonist. Dopamine receptors are present on some corticotroph tumor cells. Cabergoline activates these receptors and may reduce adrenocorticotropic hormone secretion in certain patients. Although responses can vary, some individuals achieve meaningful reductions in cortisol levels with cabergoline therapy. These medications highlight an important principle in Cushing's syndrome treatment. Doctors can target different points in the hormonal pathway. Some drugs block cortisol synthesis. Others block cortisol action. And neuromodulators work even earlier by reducing adrenocorticotropic hormone release from the pituitary gland itself. Primary adrenal insufficiency, also known as Addison's disease, occurs when the adrenal cortex is severely damaged and can no longer produce enough hormones for normal body function. In most cases, more than 90% of the adrenal cortex must be destroyed before symptoms become obvious. By that stage, the adrenal glands can no longer meet the body's hormonal demands. This leads to deficiencies of cortisol, aldosterone, and adrenal androgens all at the same time. Cortisol deficiency affects metabolism, blood pressure, stress responses, and energy balance. Patients often experience fatigue, weakness, weight loss, and low blood sugar levels. Aldosterone deficiency creates major electrolyte problems. The kidneys lose too much sodium and water while retaining potassium. As a result, patients may develop dehydration, low blood pressure, dizziness, and salt cravings. Adrenal androgen deficiency is usually more noticeable in women because these hormones contribute to body hair and libido. Since the adrenal glands are failing, the pituitary gland responds by producing large amounts of adrenocorticotropic hormone in an attempt to stimulate the cortex. High adrenocorticotropic hormone levels can cause hyperpigmentation, a classic feature of Addison's disease. The skin may appear darker, especially around scars, skin folds, elbows, knees, and the inside of the mouth. The most common cause of Addison's disease today is autoimmune adrenalitis. In this condition, the immune system mistakenly attacks and destroys the adrenal cortex. Autoimmune adrenalitis is often associated with autoimmune polyendocrine syndromes, also called APS. Autoimmune polyendocrine syndrome type 1 usually begins in childhood and may involve chronic fungal infections, hypoparathyroidism, and adrenal insufficiency. Autoimmune polyendocrine syndrome type 2 is more common in adults and is frequently associated with autoimmune thyroid disease or type 1 diabetes mellitus. Infections are another important cause of adrenal destruction. Historically, tuberculosis was one of the leading causes of Addison's disease worldwide. Tuberculosis can spread to the adrenal glands and gradually destroy adrenal tissue over time. Certain fungal infections can also damage the adrenal cortex, especially in immunocompromised patients. In individuals with HIV, AIDS, infections such as cytomegalovirus, or CMV, may invade the adrenal glands and impair hormone production. Another serious cause is bilateral adrenal hemorrhage or infarction. This can occur during severe sepsis, trauma, or clotting disorders. One well-known example is Waterhouse-Friderichsen syndrome, where overwhelming bacterial infection causes massive adrenal bleeding and acute adrenal failure. Adrenoleukodystrophy is another rare cause. This inherited disorder leads to abnormal accumulation of very long-chain fatty acids in the adrenal glands and nervous system. Over time, the adrenal cortex becomes damaged and hormone production declines. So, Addison's disease is essentially a state of adrenal gland failure. When the cortex is destroyed, the body loses critical hormones needed for stress responses, blood pressure regulation, metabolism, and survival itself. Secondary and tertiary adrenal insufficiency occur when the problem does not start in the adrenal glands themselves. Instead, the defect comes from the brain's hormonal control system. Normally, the hypothalamus releases corticotropin-releasing hormone, which stimulates the pituitary gland to produce adrenocorticotropic hormone. Adrenocorticotropic hormone then signals the adrenal cortex to release cortisol. In secondary adrenal insufficiency, the pituitary gland fails to produce enough adrenocorticotropic hormone. In tertiary adrenal insufficiency, the hypothalamus fails to produce enough corticotropin-releasing hormone. In both conditions, the adrenal glands receive too little stimulation and gradually reduce cortisol production. One of the most common causes is suppression of the hypothalamic-pituitary-adrenal axis, also called the hypothalamic-pituitary-adrenal axis, after long-term glucocorticoid therapy. Medications like prednisone, dexamethasone, or hydrocortisone can strongly suppress adrenocorticotropic hormone release when used for prolonged periods. The brain senses high steroid levels from the medication and responds by shutting down natural corticotropin-releasing hormone and adrenocorticotropic hormone production. Over time, the adrenal cortex becomes less active because it is no longer being stimulated normally. If these medications are stopped suddenly, the body may not be able to restart cortisol production fast enough. This can lead to adrenal insufficiency, especially during stress, illness, surgery, or trauma when the body urgently needs cortisol. Patients may develop fatigue, weakness, nausea, low blood pressure, dizziness, and poor stress tolerance. Unlike primary adrenal insufficiency, mineralocorticoid function usually remains normal. That is because aldosterone production mainly depends on the renin-angiotensin-aldosterone system, or RAS, rather than adrenocorticotropic hormone. The zona glomerulosa of the adrenal cortex can still respond to renin-angiotensin-aldosterone system signals and maintain sodium and potassium balance. As a result, severe electrolyte disturbances are less common than in Addison's disease. Another important difference is the absence of hyperpigmentation. In primary adrenal insufficiency, adrenocorticotropic hormone levels become very high because the pituitary tries to stimulate damaged adrenal glands. High adrenocorticotropic hormone also increases melanocyte stimulation, leading to darkened skin pigmentation. But in secondary and tertiary adrenal insufficiency, adrenocorticotropic hormone levels are actually low or inappropriately normal. Without excess adrenocorticotropic hormone, hyperpigmentation usually does not occur. Other causes of secondary adrenal insufficiency include pituitary tumors, pituitary surgery, radiation therapy, or pituitary infarction. Tertiary adrenal insufficiency may occur with hypothalamic disease or chronic suppression from exogenous steroids. The key idea is that the adrenal glands themselves are not initially damaged. Instead, they become underactive because the hormonal signals from the hypothalamus or pituitary are missing. So, Secondary and tertiary adrenal insufficiency are central endocrine disorders caused by impaired corticotropin-releasing hormone or adrenocorticotropic hormone production, leading mainly to cortisol deficiency while aldosterone function is largely preserved. Adrenal insufficiency develops when the body cannot produce enough adrenal hormones, especially cortisol. The condition often begins slowly, and the symptoms may appear vague at first. Many patients experience a gradual onset of weakness and fatigue. Everyday activities may start feeling unusually exhausting. Loss of appetite is also common. Over time, patients may develop noticeable weight loss because the body struggles to maintain normal metabolism and energy balance. Nausea and gastrointestinal discomfort frequently occur as well. Some patients may even experience vomiting or chronic abdominal symptoms. Low cortisol levels also affect blood pressure regulation. Patients often develop postural hypotension, meaning they feel dizzy or lightheaded when standing up suddenly. This happens because cortisol normally helps maintain vascular tone and supports the body's response to stress. In primary adrenal insufficiency, certain features become especially important clues. One hallmark sign is hyperpigmentation. The skin may gradually darken in areas exposed to friction or pressure, such as the knuckles, elbows, creases of the hands, scars, and gums. This occurs because the pituitary gland releases large amounts of adrenocorticotropic hormone in an attempt to stimulate the failing adrenal glands. Adrenocorticotropic hormone shares structural similarities with melanocyte-stimulating hormones, which increase melanin production and darken the skin. Another classic feature is salt craving. Because aldosterone levels are low, the kidneys lose excessive sodium and water. Patients may unconsciously crave salty foods as the body tries to restore sodium balance. If adrenal insufficiency suddenly worsens, the patient can develop an adrenal crisis, which is a life-threatening medical emergency. Adrenal crisis often occurs during severe infection, trauma, surgery, dehydration, or abrupt withdrawal of chronic steroid therapy. In this situation, the body urgently needs cortisol but cannot produce enough to respond to the stress. Patients may develop profound shock that does not respond properly to vasopressors or standard fluid therapy. Blood pressure can collapse rapidly because cortisol is essential for maintaining vascular responsiveness. Fever may also occur, especially if infection triggered the crisis. Severe abdominal pain is another important feature and may mimic a surgical emergency such as appendicitis or bowel perforation. Hypoglycemia can develop because cortisol normally supports glucose production during fasting and stress. Electrolyte abnormalities are also very common. Hyponatremia occurs due to sodium loss and impaired water balance. In primary adrenal insufficiency, hyperkalemia may develop because aldosterone deficiency reduces potassium excretion by the kidneys. Without rapid treatment, adrenal crisis can quickly become fatal. Immediate management includes intravenous fluids, glucose correction, and urgent glucocorticoid replacement. So, adrenal insufficiency can range from slowly progressive fatigue and weight loss to sudden cardiovascular collapse. The condition highlights just how essential adrenal hormones are for survival, stress adaptation, blood pressure control, and metabolic stability. The main goal of adrenal insufficiency treatment is simple: replace the hormones that the adrenal glands can no longer produce adequately. In chronic adrenal insufficiency, lifelong hormone replacement therapy is usually required. The most important hormone to replace is cortisol. Doctors commonly use glucocorticoid medications such as hydrocortisone, cortisone acetate, or prednisone. These drugs help restore normal metabolism, blood pressure, energy levels, and stress responses. Treatment is designed to mimic the body's natural diurnal rhythm of cortisol secretion. Normally, cortisol levels are highest in the early morning and gradually decline throughout the day. That is why glucocorticoid doses are usually given in larger amounts in the morning and smaller amounts later in the day. Hydrocortisone is often preferred because it closely resembles natural cortisol. With proper dosing, many patients regain energy, appetite, and improved quality of life. However, dosing must be carefully balanced. Too little steroid replacement can leave patients fatigued and vulnerable to adrenal crisis. Too much can produce symptoms similar to Cushing's syndrome. In primary adrenal insufficiency, another hormone must also be replaced: aldosterone. Aldosterone normally helps the kidneys retain sodium and water while excreting potassium. Without it, patients can develop dehydration, low blood pressure, and dangerous electrolyte imbalances. To replace this function, patients are given fludrocortisone, a synthetic mineralocorticoid. Fludrocortisone helps maintain blood pressure, sodium balance, and fluid volume. Patients with primary adrenal insufficiency are also encouraged to maintain a liberal salt intake, especially during hot weather, heavy exercise, or illness when sodium losses increase. Some women with adrenal insufficiency may also experience low libido, poor mood, or reduced sense of well-being because of adrenal androgen deficiency. In selected cases, DHEA replacement may be considered. DHEA is an adrenal androgen precursor that can improve energy, mood, and sexual well-being in some patients. Patients must also learn how to adjust medication during stress. During infections, surgery, trauma, or severe illness, the body normally requires more cortisol. This is called stress dosing, and glucocorticoid doses must be temporarily increased to prevent adrenal crisis. Acute adrenal crisis is a medical emergency and requires immediate treatment. The first priority is aggressive intravenous fluid resuscitation, usually with normal saline combined with dextrose. This helps correct dehydration, low blood pressure, and hypoglycemia. At the same time, high-dose intravenous hydrocortisone is administered immediately. Hydrocortisone is especially useful because it provides both glucocorticoid and some mineralocorticoid activity during the emergency phase. Rapid treatment can be life-saving because adrenal crisis may quickly progress to severe shock and organ failure if untreated. So, adrenal insufficiency pharmacotherapy focuses on replacing missing hormones, mimicking natural physiology, and preparing patients to respond safely during times of physical stress. Hyperaldosteronism, also called Conn's syndrome, is a condition where the adrenal glands produce too much aldosterone. The key problem is that aldosterone secretion becomes autonomous, meaning it no longer follows normal regulatory control. Under normal conditions, aldosterone release is controlled mainly by the renin-angiotensin-aldosterone system, or RAAS. This system responds to blood pressure, blood volume, and potassium levels. In Conn's syndrome, the adrenal cortex produces aldosterone independently of the renin-angiotensin-aldosterone system. Even when the body does not need extra aldosterone, hormone production continues. Excess aldosterone causes the kidneys to retain sodium and water while excreting potassium. As sodium and water retention increase, blood volume expands and hypertension develops. At the same time, potassium loss can lead to hyperkalemia, causing muscle weakness, cramps, fatigue, and sometimes cardiac arrhythmias. One major cause of primary hyperaldosteronism is a unilateral aldosterone-producing adenoma, often called an ARPA. This is usually a benign tumor arising from the zona glomerulosa of one adrenal gland. The adenoma continuously secretes aldosterone regardless of renin-angiotensin-aldosterone system signals, leading to persistent hypertension and potassium imbalance. Another common cause is bilateral idiopathic hyperaldosteronism. In this condition, both adrenal glands become hyperactive and overproduce aldosterone diffusely rather than from a single tumor. Patients with bilateral disease often develop chronic high blood pressure that may be resistant to standard antihypertensive medications. Research has revealed important genetic mechanisms behind some aldosterone-producing adenomas. One of the most significant discoveries involves mutations in the KCNJ5 potassium channel gene. This gene normally helps regulate potassium movement across adrenal cell membranes. When mutations occur, adrenal cells become abnormally depolarized. This increases calcium entry into the cells and stimulates excessive aldosterone synthesis. These KCNJ5 mutations are heavily implicated in many aldosterone-producing adenomas and have improved our understanding of adrenal endocrine tumors. There is also a rare inherited form called glucocorticoid-remediable aldosteronism, or GRA. This familial disorder results from a chimeric gene formed by abnormal fusion of CYP11B1 and CYP11B2 genes. Normally, CYP11B1 is involved in cortisol synthesis and regulated by adrenocorticotropic hormone, while CYP11B2 controls aldosterone production in response to renin-angiotensin-aldosterone system signals. In glucocorticoid-remediable aldosteronism, the abnormal chimeric gene causes aldosterone production to become adrenocorticotropic hormone dependent. This means aldosterone secretion rises under pituitary control rather than normal renin-angiotensin-aldosterone system regulation. Interestingly, glucocorticoid therapy can suppress adrenocorticotropic hormone release and reduce aldosterone production in these patients. That is why the condition is called glucocorticoid remediable. So, the central feature of Conn's syndrome is uncontrolled aldosterone secretion. Whether caused by tumors, adrenal hyperplasia, or genetic mutations, excess aldosterone disrupts blood pressure regulation and electrolyte balance throughout the body. Hyperaldosteronism often presents with persistent high blood pressure that becomes difficult to control. Many patients require several antihypertensive medications, yet the blood pressure remains elevated. This is why the condition is sometimes called refractory hypertension. The underlying problem is excess aldosterone production from the adrenal cortex. Aldosterone tells the kidneys to retain sodium and water while increasing potassium excretion. As sodium and water accumulate, blood volume expands and blood pressure rises. At the same time, excessive potassium loss leads to hyperkalemia. Low potassium levels can affect muscles, nerves, and even the heart. Many patients develop muscle weakness, fatigue, muscle cramps, or occasional paralysis in severe cases. Another important finding is hyperkalemic metabolic alkalosis. This happens because the kidneys lose hydrogen ions along with potassium, causing the blood to become more alkaline. Excess aldosterone also affects kidney function and water handling. Patients may develop polyuria, meaning they urinate frequently. Because large amounts of fluid are lost in the urine, polydipsia, or excessive thirst, commonly follows. Some patients experience headaches, palpitations, or numbness related to electrolyte imbalance and uncontrolled hypertension. Diagnosis usually begins with laboratory testing. The classic pattern is elevated plasma aldosterone levels together with suppressed plasma renin activity, also called PRA. Normally, high blood pressure would suppress renin-angiotensin-aldosterone system activation and reduce aldosterone production. But in primary hyperaldosteronism, aldosterone secretion continues autonomously despite low renin levels. This creates a high aldosterone to renin ratio, which is an important screening clue for the disease. Treatment depends on the underlying cause. If a patient has a unilateral aldosterone-producing adenoma, surgical removal of the affected adrenal gland may provide a cure. However, patients with bilateral adrenal hyperplasia or non-surgical disease are usually treated medically. The cornerstone of pharmacotherapy is mineralocorticoid receptor antagonists. These drugs block aldosterone from acting on the kidneys. One commonly used medication is spironolactone. It reduces sodium retention, lowers blood pressure, and helps correct potassium loss. As potassium levels normalize, symptoms like muscle weakness and fatigue often improve significantly. However, spironolactone can also interact with androgen and progesterone receptors, sometimes causing gynecomastia or menstrual irregularities. Eplerenone is another mineralocorticoid receptor antagonist. It works similarly but is more selective and tends to produce fewer hormonal side effects. In glucocorticoid remediable aldosteronism, or GRA, treatment works differently. Because aldosterone production is abnormally driven by adrenocorticotropic hormone, low-dose glucocorticoids such as dexamethasone can suppress adrenocorticotropic hormone release from the pituitary gland. As adrenocorticotropic hormone levels fall, aldosterone secretion also decreases. So, hyperaldosteronism is ultimately a disorder of uncontrolled aldosterone activity. The condition disrupts blood pressure regulation, electrolyte balance, and kidney function, but targeted therapy can dramatically improve symptoms and long-term cardiovascular outcomes. Pheochromocytoma is a rare but fascinating endocrine tumor that arises from chromaffin cells of the adrenal medulla. These specialized cells normally produce catecholamines such as epinephrine and norepinephrine. Under normal conditions, catecholamines help the body respond to stress through the fight or flight response. They increase heart rate, blood pressure, and alertness during emergencies. In pheochromocytoma, the tumor secretes excessive catecholamines in an uncontrolled and unpredictable way. This causes sudden surges of sympathetic nervous system activity throughout the body. Some tumors release hormones continuously, while others produce dramatic episodic bursts. The condition can occur sporadically, but a significant number of cases are linked to inherited genetic syndromes. One important association is multiple endocrine neoplasia type 2, also called MEN2. Patients with multiple endocrine neoplasia type 2 may develop pheochromocytomas along with medullary thyroid carcinoma and parathyroid disease. Another inherited condition is von Hippel-Lindau syndrome, which involves tumors affecting multiple organs including the adrenal glands, kidneys, retina, and central nervous system. Neurofibromatosis type 1 is also associated with pheochromocytoma in some patients. These genetic syndromes highlight how mutations affecting cellular growth and signaling pathways can predispose individuals to endocrine tumors. In rare situations, pheochromocytomas may produce hormones other than catecholamines. Some tumors can ectopically secrete adrenocorticotropic hormone, which overstimulates the adrenal cortex and causes concurrent Cushing's syndrome. This creates a complex endocrine picture where patients experience symptoms of both catecholamine excess and hypercortisolism at the same time. The classic clinical presentation of pheochromocytoma is often described as a triad. The first symptom is episodic headaches. These headaches may be severe, pounding, and sudden in onset. The second hallmark feature is excessive sweating, also called diaphoresis. Patients may suddenly become drenched in sweat during catecholamine surges. The third classic symptom is palpitations or tachycardia. The heart may race rapidly, sometimes accompanied by chest discomfort or anxiety. These episodes are usually associated with hypertension, which may be persistent or paroxysmal. During catecholamine bursts, blood pressure can rise dramatically and become dangerously high. Patients often describe attacks that come suddenly and disappear unexpectedly. Episodes may last minutes to hours. Triggers can include stress, exercise, surgery, certain medications, or even changes in body position. Other symptoms may include tremors, pallor, panic-like feelings, weight loss, or heat intolerance. Because the symptoms mimic panic attacks or anxiety disorders, diagnosis may sometimes be delayed. However, untreated pheochromocytoma can be extremely dangerous due to severe hypertension, arrhythmias, stroke, or cardiovascular collapse. So, pheochromocytoma is essentially a tumor of uncontrolled catecholamine release. The adrenal medulla becomes a powerful source of excessive sympathetic stimulation, producing dramatic cardiovascular and metabolic effects throughout the body. The definitive treatment for pheochromocytoma is surgical removal of the tumor. Once the catecholamine-secreting mass is removed, many patients experience dramatic improvement in symptoms and blood pressure control. However, surgery for pheochromocytoma can be extremely dangerous if the patient is not prepared properly beforehand. During surgery, even touching or manipulating the tumor can trigger massive catecholamine release into the bloodstream. This sudden hormone surge can cause severe hypertensive crises, dangerous arrhythmias, stroke, or even cardiac arrest. That is why preoperative pharmacotherapy is one of the most critical steps in management. Before surgery, doctors must stabilize blood pressure and reduce the effects of excessive catecholamine stimulation. The traditional approach begins with alpha-adrenergic blockade. Alpha receptors normally cause blood vessels to constrict in response to catecholamines like norepinephrine. In pheochromocytoma, excessive catecholamine release keeps these receptors constantly stimulated, leading to severe vasoconstriction and hypertension. Alpha blockers relax blood vessels and reduce peripheral vascular resistance. This helps lower blood pressure and improve circulation before surgery. One classic medication used is phenoxybenzamine, a non-selective irreversible alpha blocker. Phenoxybenzamine gradually reduces blood pressure and helps protect the patient from sudden catecholamine surges during tumor manipulation. Selective alpha-1 blockers such as doxazosine may also be used in some patients. As blood vessels relax, patients often develop improved blood flow and reduced hypertensive symptoms. Doctors also encourage liberal salt and fluid intake during preparation. This is important because chronic vasoconstriction often leaves patients relatively volume depleted despite high blood pressure. Restoring intravascular volume helps prevent severe postoperative hypotension after the tumor is removed. Once adequate alpha blockade is established, beta blockers may sometimes be added to control persistent tachycardia or palpitations. However, beta blockers should never be started before alpha blockade. If beta receptors are blocked first, catecholamines continue stimulating alpha receptors unopposed, which can trigger dangerous vasoconstriction and extreme hypertension. Careful blood pressure monitoring is essential throughout the preoperative period. Doctors aim to achieve stable blood pressure both while sitting and standing before proceeding to surgery. During the operation itself, anesthesiologists closely monitor cardiovascular status because blood pressure fluctuations can still occur rapidly. After tumor removal, catecholamine levels fall dramatically. This sudden hormonal drop may lead to hypotension, requiring careful fluid management and monitoring after surgery. Successful surgical resection often cures the condition, especially in benign localized tumors. So, pheochromocytoma management is not just about removing the tumor. The key challenge is safely controlling the body's powerful catecholamine surges before, during, and after surgery. Congenital adrenal hyperplasia, or CAH, is a group of inherited disorders that affect cortisol synthesis in the adrenal cortex. These conditions are usually inherited in an autosomal recessive pattern, meaning a child must receive defective genes from both parents. The central problem in congenital adrenal hyperplasia is an enzyme deficiency within the steroid synthesis pathway. Because the adrenal glands cannot produce cortisol normally, the entire hormonal balance becomes disrupted. Normally, cortisol provides negative feedback to the hypothalamus and pituitary gland through the hypothalamic-Pituitary-Adrenal axis. When cortisol levels fall, the pituitary responds by increasing adrenocorticotropic hormone secretion in an attempt to stimulate the adrenal glands. In congenital adrenal hyperplasia, the adrenal glands still cannot make enough cortisol despite high adrenocorticotropic hormone stimulation. As adrenocorticotropic hormone levels continue rising, the adrenal cortex becomes chronically overstimulated and enlarges over time. This leads to bilateral adrenal hyperplasia. The most common form of congenital adrenal hyperplasia is 21-hydroxylase deficiency, which accounts for more than 90% of cases. This disorder is caused by mutations in the CYP21A2 gene, which encodes the 21-hydroxylase enzyme. Normally, 21-hydroxylase is essential for the production of both cortisol and aldosterone. When the enzyme is defective, steroid precursors cannot move efficiently down the cortisol synthesis pathway. Instead, these accumulated precursors are diverted into androgen production pathways. As androgen levels rise, patients develop signs of excess androgen exposure. In genetic females, virilization may occur before birth. External genitalia can become masculinized due to excessive fetal androgen exposure. In boys, symptoms may appear later as early puberty, rapid growth, acne, or excessive body hair. Although children may initially grow rapidly, early closure of growth plates can eventually reduce final adult height. Some forms of 21-hydroxylase deficiency also impair aldosterone production. Without enough aldosterone, the kidneys lose excessive sodium and water while retaining potassium. This creates the dangerous, salt-wasting, form of congenital adrenal hyperplasia. Affected infants may develop dehydration, vomiting, weight loss, low blood pressure, hyponatremia, and hyperkalemia within the first weeks of life. Without treatment, severe salt-wasting crises can become life-threatening. The severity of disease depends on how much enzyme activity remains. Some patients have classic severe disease, while others have milder non-classic forms that present later in childhood or adulthood. The key concept in congenital adrenal hyperplasia is hormonal imbalance caused by blocked cortisol synthesis. Low cortisol increases adrenocorticotropic hormone release, Chronic adrenocorticotropic hormone stimulation enlarges the adrenal glands, and excess steroid precursors are redirected into androgen production. So, congenital adrenal hyperplasia is both a disorder of hormone deficiency and hormone excess occurring at the same time. Congenital adrenal hyperplasia, or CAH, includes several different enzyme deficiencies, and each variant creates a unique hormonal imbalance inside the adrenal cortex. Although all forms involve impaired cortisol synthesis, the specific enzyme affected determines which hormones accumulate and which hormones become deficient. One important variant is 11-beta-hydroxylase deficiency. In this disorder, the adrenal glands cannot efficiently convert 11-deoxycortisol into cortisol. As cortisol production falls, adrenocorticotropic hormone levels rise through loss of negative feedback, causing adrenal hyperplasia and excess androgen production. But another hormone precursor also builds up, 11-deoxycorticosterone, often called DOC. 11-deoxycorticosterone has strong mineralocorticoid activity, meaning it behaves similarly to aldosterone. As 11-deoxycorticosterone levels increase, the kidneys retain sodium and water, causing hypertension. Because blood pressure rises independently of the renin-angiotensin system, patients usually develop low renin hypertension. At the same time, excess androgen production leads to hyperandrogenism. Genetic females may develop virilization or ambiguous genitalia, while boys may show signs of early puberty and rapid growth. Another rare form is 3-beta-hydroxysteroid dehydrogenase deficiency. This enzyme is needed early in the steroid synthesis pathway for production of glucocorticoids, mineralocorticoids, and sex steroids. When the enzyme is defective, multiple hormone pathways become impaired simultaneously. Patients often develop severe salt wasting because aldosterone production is reduced. Infants may present with dehydration, vomiting, low blood pressure, hyponatremia, and hyperkalemia soon after birth. Unlike some other forms of congenital adrenal hyperplasia, ambiguous genitalia may occur in both sexes because normal androgen synthesis is disrupted. Genetic males may have under-virilized external genitalia, while genetic females may also show genital abnormalities due to altered steroid production. Another important variant is 17-alpha-hydroxylase deficiency. This enzyme is required for both cortisol and sex steroid synthesis. When it is deficient, production of cortisol, androgens, and estrogens decreases dramatically. Because sex steroid synthesis is impaired, patients often develop sexual infantilism. Puberty may fail to occur normally, and secondary sexual characteristics remain underdeveloped. Genetic females may experience absent menstruation, while genetic males may have under-virilized genitalia. Interestingly, despite low cortisol levels, these patients usually develop hypertension rather than salt wasting. This occurs because steroid precursors are diverted into 11-deoxycorticosterone production. Like in 11-beta-hydroxylase deficiency, excess 11-deoxycorticosterone acts as a mineralocorticoid and causes sodium retention, low renin hypertension, and hyperkalemia. These clinical variants show how a single enzyme defect can dramatically alter endocrine physiology. Depending on which hormone pathways are blocked, patients may develop combinations of cortisol deficiency, androgen excess, sexual development disorders, hypertension, or salt-wasting crises. So, congenital adrenal hyperplasia is not one single disease. It is a spectrum of inherited enzyme disorders that reshape adrenal hormone production in very different ways. The management of congenital adrenal hyperplasia, or CAH, focuses on restoring hormonal balance and preventing the long-term complications of cortisol deficiency and excess androgen production. The cornerstone of treatment is glucocorticoid replacement therapy. Hydrocortisone is commonly used, especially in children, because it closely resembles natural cortisol. Replacing cortisol does more than correct hormone deficiency. It also restores negative feedback to the hypothalamic-Pituitary-Adrenal axis. As cortisol levels normalize, adrenocorticotropic hormone secretion from the pituitary gland decreases. This is extremely important because excessive adrenocorticotropic hormone stimulation drives adrenal hyperplasia and overproduction of adrenal androgens. By suppressing adrenocorticotropic hormone, glucocorticoid therapy reduces abnormal androgen excess and helps prevent progressive virilization. Treatment must be carefully balanced. Too little glucocorticoid allows continued adrenocorticotropic hormone overproduction, while excessive dosing can impair growth and produce Cushing-like side effects. In salt-wasting forms of congenital adrenal hyperplasia, mineralocorticoid replacement is also essential. Fludrocortisone is commonly prescribed to replace aldosterone function. This helps the kidneys retain sodium and water while promoting potassium excretion. Infants with severe salt-wasting disease often require additional sodium chloride supplementation, especially during early life when sodium requirements are high. Without proper mineralocorticoid replacement, patients can develop dehydration, hypotension, hyponatremia, and potentially life-threatening adrenal crises. Monitoring growth, blood pressure, electrolytes, and hormone levels becomes an important part of long-term management. Some females with severe prenatal androgen exposure may be born with significant virilization of the external genitalia. In selected cases, surgical correction may be considered. Procedures such as vaginoplasty or clitoroplasty may help reconstruct genital anatomy and improve urinary or reproductive function. These decisions are highly individualized and often involve careful discussions between families, endocrinologists, surgeons, and mental health professionals. Another complex aspect of congenital adrenal hyperplasia management involves prenatal treatment. In pregnancies at risk for classic 21-hydroxylase deficiency, early maternal dexamethasone therapy has been used experimentally to reduce fetal adrenocorticotropic hormone stimulation and decrease androgen exposure in affected female fetuses. The goal is to prevent or reduce virilization before birth. Because fetal genital development begins very early, treatment must start during the first trimester, often before definitive genetic diagnosis is available. However, this approach remains controversial. Concerns exist regarding potential long-term effects of prenatal glucocorticoid exposure on both the fetus and the mother. For this reason, prenatal dexamethasone therapy is generally considered only in specialized centers with extensive experience. Modern congenital adrenal hyperplasia management requires lifelong endocrine follow-up and individualized care. The overall goal is not only survival, but also healthy growth, normal development, hormonal stability, and improved quality of life throughout childhood and adulthood. Adrenocortical carcinoma, also called ACC, is a rare but highly aggressive cancer that arises from the adrenal cortex. Although uncommon, it is one of the most serious adrenal endocrine disorders because it often grows rapidly and spreads early. The pathogenesis of adrenocortical carcinoma involves several important genetic and molecular abnormalities. One major association is mutation of the TP53 tumor suppressor gene. TP53 normally helps regulate cell growth and prevent damaged cells from becoming cancerous. When TP53 is mutated, abnormal adrenal cortical cells can grow uncontrollably. These mutations are strongly linked to Li-Fraumeni syndrome, a hereditary cancer predisposition disorder associated with multiple aggressive malignancies. Another important mechanism involves abnormalities at the 11p15 chromosomal locus. This region contains genes involved in growth regulation, including IGF-2, or insulin-like growth factor 2. In many adrenocortical carcinoma tumors, insulin-like growth factor 2 becomes overexpressed, driving rapid cellular proliferation and tumor growth. The WNT, beta-catenin signaling pathway is also heavily implicated in adrenocortical carcinoma development. Mutations in the CTNNB1 gene can activate beta-catenin signaling abnormally, promoting uncontrolled adrenal cell division and tumor progression. Clinically, most adrenocortical carcinomas are functional tumors. In fact, about 60 to 80% actively secrete hormones. Because these tumors often produce multiple adrenal steroids simultaneously, patients may develop rapid mixed endocrine syndromes. For example, a patient may show features of Cushing's syndrome together with virilization or hyperandrogenism. Women may develop hirsutism, deepening of the voice, acne, or menstrual irregularities due to excessive androgen production. Children may present with precocious puberty caused by excess adrenal hormones. Laboratory testing often reveals elevated DHEAS or increased levels of steroid precursors such as 11-deoxycortisol. These abnormal hormone patterns can provide important clues pointing toward adrenal malignancy rather than a simple benign adenoma. The cornerstone of treatment is surgical resection. Open adrenalectomy with complete tumor removal and negative surgical margins, also called an R0 resection, offers the best chance for long-term survival. Complete removal is extremely important because residual tumor tissue can rapidly regrow or metastasize. Even after surgery, recurrence rates remain high, so patients require close follow-up. For advanced or metastatic disease, pharmacotherapy becomes essential. One key medication is mitotane, an adrenoliptic drug that selectively damages adrenal cortical cells while also suppressing steroid production. Because mitotane reduces cortisol synthesis significantly, patients often require glucocorticoid replacement therapy during treatment. Advanced adrenocortical carcinoma may also be treated with combination chemotherapy known as EDPM. This regimen includes etoposide, doxorubicin, cisplatin, and mitotane. Although adrenocortical carcinoma remains challenging to treat, combining surgery, hormonal control, and systemic therapy can improve outcomes and help manage this aggressive endocrine cancer. In Section 2, we will discuss a few case reviews. This patient has classic features of Cushing's syndrome. The central obesity, severe facial plethora, and wide violaceous striae strongly point toward chronic cortisol excess. The laboratory findings help narrow down the cause even further. Her cortisol levels remain elevated despite dexamethasone suppression testing. This suggests autonomous cortisol production that is not responding to normal feedback mechanisms. At the same time, adrenocorticotropic hormone levels are undetectable. That finding is extremely important because it tells us the condition is adrenocorticotropic hormone independent. In adrenocorticotropic hormone independent Cushing's syndrome, the adrenal gland itself is producing cortisol autonomously. The unilateral adrenal mass seen on imaging strongly supports an adrenal adenoma or adrenal tumor as the source of excess cortisol production. Normally, surgical removal of the adrenal mass would be the preferred treatment. However, this patient is described as an exceptionally poor surgical candidate, so medical therapy becomes necessary. The question asks for a steroidogenesis inhibitor that blocks multiple CYP enzymes, including 11-beta-hydroxylase and 17,20-LYESS. The correct answer is ketoconazole. Ketoconazole is best known as an antifungal medication, but it also suppresses adrenal steroid synthesis. It inhibits several cytochrome P450 enzymes involved in cortisol production within the adrenal cortex. Two major targets are 11-beta-hydroxylase and 17,20-LYESS. By blocking these enzymes, ketoconazole reduces cortisol synthesis and helps control the symptoms of hypercortisolism. Patients may experience improvements in blood pressure, blood sugar, muscle weakness, and weight gain as cortisol levels decline. Now let's quickly review why the other options are incorrect. Mifepristone is a glucocorticoid receptor antagonist. It blocks cortisol action at the receptor level but does not inhibit steroidogenesis enzymes directly. Pasireotide is a somatostatin analog that reduces adrenocorticotropic hormone secretion from pituitary tumors. It is mainly used in adrenocorticotropic hormone-dependent Cushing's disease, not adrenal cortisol-producing tumors. Cabergoline is a dopamine agonist that can also suppress adrenocorticotropic hormone release in some pituitary adenomas. Again, it targets central adrenocorticotropic hormone production rather than adrenal steroid synthesis itself. Ketoconazole is unique among these options because it directly inhibits multiple adrenal steroid synthesis enzymes. So, the key clues in this case are adrenocorticotropic hormone suppression, the unilateral adrenal mass, and the need for a multi-enzyme steroidogenesis inhibitor. That combination clearly points to ketoconazole as the correct answer. This patient is presenting with an adrenal crisis, which is a life-threatening endocrine emergency caused by severe adrenal insufficiency. Several clues in the case point directly toward this diagnosis. She has a history of autoimmune polyendocrine syndrome, a condition strongly associated with autoimmune destruction of the adrenal cortex and primary adrenal insufficiency, also known as Addison's disease. Now look at the symptoms. She arrives with profound hypotension that is resistant to vasopressors. This is a major red flag because cortisol is essential for maintaining vascular responsiveness and blood pressure. Without adequate cortisol, blood vessels cannot respond properly to catecholamines or vasopressor medications. The fever and acute abdominal pain are also classic features of adrenal crisis. In fact, adrenal crisis can sometimes mimic a surgical abdomen. The laboratory findings make the diagnosis even clearer. Hypoglycemia occurs because cortisol normally supports glucose production during stress and fasting states. Hyponatremia develops due to sodium loss and impaired water balance. Hyperkalemia strongly suggests aldosterone deficiency, which is typical of primary adrenal insufficiency. Together, these findings point toward acute adrenal failure with both glucocorticoid and mineralocorticoid deficiency. The most appropriate immediate treatment is intravenous normal saline with dextrose and high-dose intravenous hydrocortisone. That makes answer the correct choice. Aggressive IV fluid resuscitation is essential because these patients are often severely dehydrated and hypotensive. Normal saline helps restore intravascular volume and improve blood pressure. Dextrose is added to correct hypoglycemia and support metabolic needs. High-dose intravenous hydrocortisone is the cornerstone of emergency treatment. Hydrocortisone rapidly replaces deficient cortisol and also provides some mineralocorticoid activity, which helps improve sodium balance and vascular stability. Immediate steroid replacement can be life-saving in adrenal crisis. Now let's review why the other options are incorrect. Oral fludrocortisone and increased salt intake are used in chronic outpatient management of primary adrenal insufficiency, not in an acute emergency with shock. Intravenous etomidate is used to rapidly suppress cortisol synthesis in severe Cushing's syndrome, which is the exact opposite endocrine problem. Spironolactone is a mineralocorticoid receptor antagonist used in hyperaldosteronism. It would worsen hyperkalemia and hypotension in this patient. The key lesson in this case is rapid recognition of adrenal crisis. When a patient with adrenal insufficiency develops severe hypotension, abdominal pain, hypoglycemia, hyponatremia, and hyperkalemia, treatment must begin immediately. Early IV fluids and high-dose hydrocortisone can quickly reverse shock and prevent fatal cardiovascular collapse. This patient has classic findings of primary hyperaldosteronism. The refractory hypertension, polyuria, and hyperkalemic alkalosis strongly point toward excessive aldosterone activity. Let's break down the physiology step by step. Aldosterone acts on the kidneys to retain sodium and water while increasing potassium and hydrogen ion excretion. As sodium and water retention increase, blood pressure rises. At the same time, potassium loss leads to hyperkalemia, while hydrogen ion loss produces metabolic alkalosis. Low potassium levels can also impair kidney concentrating ability, causing polyuria and excessive thirst. The laboratory findings confirm the diagnosis. The patient has elevated aldosterone levels together with suppressed plasma renin activity. Normally, high blood pressure would suppress the renin-angiotensin-aldosterone system, lowering aldosterone production. But in primary hyperaldosteronism, aldosterone secretion becomes autonomous and continues despite low renin levels. The key clue in this question is the diagnosis of glucocorticoid-remediable aldosteronism, or GRA. This is a rare inherited form of hyperaldosteronism caused by a chimeric CYP11B1, CYP11B2 gene. Normally, CYP11B1 helps produce cortisol and is regulated by adrenocorticotropic hormone, while CYP11B2 controls aldosterone synthesis in response to the renin-angiotensin system. In glucocorticoid-remediable aldosteronism, these genes become abnormally fused together. As a result, aldosterone production becomes driven by adrenocorticotropic hormone instead of normal renin-angiotensin-aldosterone system signaling. That means the pituitary gland indirectly stimulates excessive aldosterone secretion. The best treatment is low-dose dexamethasone, making answer a correct. Dexamethasone suppresses adrenocorticotropic hormone release from the pituitary gland through negative feedback. As adrenocorticotropic hormone levels fall, the abnormal adrenocorticotropic hormone-driven aldosterone production also decreases. This directly targets the underlying pathophysiology of glucocorticoid-remediable aldosteronism. Patients often experience improvement in blood pressure and potassium levels once aldosterone secretion is suppressed. Now let's review why the other choices are incorrect. High-dose fludrocortisone would worsen the condition because it acts like aldosterone and would further increase sodium retention and hypertension. Eplerenone is a mineralocorticoid receptor antagonist and can help block aldosterone effects in some forms of hyperaldosteronism. However, the question specifically asks for therapy that suppresses the abnormal aldosterone production itself. Low-dose dexamethasone addresses the adrenocorticotropic hormone-driven mechanism directly, making it the preferred answer. Mitotane is an adrenoliptic drug used mainly in adrenocortical carcinoma and severe Cushing's syndrome. It has no role in treating glucocorticoid-remediable aldosteronism. The major lesson here is understanding the unique endocrine mechanism behind glucocorticoid-remediable aldosteronism. Because aldosterone secretion becomes adrenocorticotropic hormone-dependent, suppressing adrenocorticotropic hormone with low-dose glucocorticoids can effectively control the disease. This patient has classic features of pheochromocytoma, a catecholamine-secreting tumor arising from chromaffin cells of the adrenal medulla. The episodic headaches, severe sweating, palpitations, and extreme hypertension form the classic clinical picture of catecholamine excess. During attacks, his blood pressure rises dramatically to 220/110 mm of mercury, which is dangerously high. These sudden hypertensive episodes occur because the tumor releases excessive amounts of epinephrine and norepinephrine into the bloodstream. Catecholamines strongly stimulate the sympathetic nervous system, triggering intense vasoconstriction, tachycardia, and cardiovascular stress. The adrenal medullary mass seen on imaging confirms the likely diagnosis of pheochromocytoma. Definitive treatment is surgical removal of the tumor. However, surgery itself can be extremely dangerous if the patient is not properly prepared beforehand. During tumor manipulation, massive catecholamine surges can suddenly occur. This may trigger severe hypertensive crises, arrhythmias, stroke, myocardial infarction, or even cardiac arrest. That is why careful preoperative pharmacologic preparation is absolutely essential. The traditional and most important strategy is alpha-adrenergic blockade, making answer B the correct choice. Alpha receptors normally cause blood vessels to constrict when stimulated by catecholamines. In pheochromocytoma, continuous catecholamine excess keeps blood vessels in a highly constricted state, producing severe hypertension. Alpha blockers relax vascular smooth muscle and reduce peripheral vasoconstriction. This helps stabilize blood pressure before surgery and reduces the risk of catastrophic intraoperative hypertensive episodes. One classic medication used is phenoxybenzamine, a non-selective irreversible alpha blocker. Selective alpha-1 blockers such as doxazosine may also be used in some patients. Patients are often encouraged to increase salt and fluid intake during preparation because chronic vasoconstriction can leave them relatively volume depleted. Now let's discuss why the other options are incorrect. Beta-adrenergic blockade alone before alpha blockade is dangerous. If beta receptors are blocked first, catecholamines continue stimulating alpha receptors without opposition, causing severe vasoconstriction and potentially life-threatening hypertension. Beta blockers may be added later only after adequate alpha blockade is established. Mitotane is an adrenoliptic drug used mainly for adrenocortical carcinoma and certain cases of severe Cushing's syndrome. It has no role in pheochromocytoma preparation. Ketoconazole inhibits adrenal steroid synthesis and is used in hypercortisolism, not catecholamine-secreting tumors. The key lesson in this case is that pheochromocytoma surgery requires careful endocrine and cardiovascular preparation. Alpha-adrenergic blockade is the cornerstone of preoperative management because it protects the patient from dangerous catecholamine-induced hypertensive crises during tumor removal. This newborn is showing classic features of congenital adrenal hyperplasia, also called CAH. The key findings are ambiguous genitalia, severe salt wasting, low cortisol, low aldosterone, and very high adrenocorticotropic hormone levels. Together, these findings strongly point toward 21-hydroxylase deficiency, which is the most common form of congenital adrenal hyperplasia. The correct answer is CYP21A2, making choice D correct. Let's break down why this happens. The CYP21A2 gene encodes the 21-hydroxylase enzyme, which is essential for cortisol and aldosterone synthesis in the adrenal cortex. When this enzyme is defective, the adrenal glands cannot produce adequate cortisol. As cortisol levels fall, the hypothalamic-pituitary-adrenal axis loses negative feedback control. The pituitary gland responds by releasing large amounts of adrenocorticotropic hormone in an attempt to stimulate the adrenal cortex. Chronic adrenocorticotropic hormone stimulation causes bilateral adrenal hyperplasia and excessive accumulation of steroid precursors. Because these precursors cannot move efficiently into the cortisol pathway, they are redirected into androgen synthesis pathways instead. This leads to excessive androgen production during fetal development. In genetic females, high prenatal androgen exposure can cause virilization and ambiguous genitalia at birth. The severe salt wasting seen in this newborn is another critical clue. Since 21-hydroxylase is also required for aldosterone synthesis, aldosterone levels become very low. Without aldosterone, the kidneys lose excessive sodium and water while retaining potassium. This can rapidly lead to dehydration, hyponatremia, hypokalemia, hypotension, and potentially life-threatening adrenal crisis in newborns. Now let's review why the other options are incorrect. CYP11B1 mutations cause 11-beta-hydroxylase deficiency, another form of congenital adrenal hyperplasia. However, those patients usually develop hypertension because of excess 11-deoxycorticosterone, not severe salt wasting. CTNNB1 mutations are associated with abnormal beta-catenin signaling and are linked to adrenocortical carcinoma, not classic congenital adrenal hyperplasia. KCNJ5 mutations are associated with aldosterone-producing adenomas in primary hyperaldosteronism, especially Conn's syndrome. The combination of ambiguous genitalia and salt-wasting adrenal insufficiency is the hallmark of classic 21-hydroxylase deficiency. This is why CYP21A2 mutations account for more than 90% of congenital adrenal hyperplasia cases worldwide. Early diagnosis is extremely important because untreated salt-wasting congenital adrenal hyperplasia can quickly become fatal in infancy. Treatment usually includes glucocorticoid replacement to suppress adrenocorticotropic hormone and restore cortisol levels, along with mineralocorticoid replacement and sodium supplementation for salt-wasting disease. So, this case perfectly demonstrates how a single enzyme defect in adrenal steroid synthesis can create both hormone deficiency and androgen excess at the same time. This patient has several alarming features that strongly suggest adrenocortical carcinoma, also called ACC. The rapid onset of symptoms is a major clue. Benign endocrine disorders usually develop gradually, but aggressive adrenal cancers often produce symptoms quickly and dramatically. She presents with central obesity, severe hirsutism, and virilization. That combination suggests excessive production of both glucocorticoids and adrenal androgens. The laboratory findings support this even further. Markedly elevated DHEAS points toward excessive adrenal androgen secretion. At the same time, elevated 11-deoxycortisol suggests abnormal steroid synthesis within a malignant adrenal cortical tumor. The imaging findings are also concerning. A large, heterogeneous adrenal mass is much more suspicious for carcinoma than for a simple adrenal adenoma. Together, the hormonal abnormalities and tumor appearance strongly indicate a functional adrenocortical carcinoma. Surgical resection is the cornerstone of treatment. However, adrenocortical carcinoma has a high risk of recurrence and metastasis, so adjuvant therapy is often required even after surgery. The question asks for an adrenoliptic agent that requires concomitant high-dose glucocorticoid replacement. The correct answer is mitotane. Mitotane is a specialized adrenoliptic drug that selectively damages adrenal cortical cells. It suppresses adrenal steroid production and can help control both tumor growth and hormone excess in adrenocortical carcinoma. Because mitotane destroys functioning adrenal tissue, cortisol production can fall dramatically during treatment. As a result, patients often require high-dose glucocorticoid replacement therapy to prevent adrenal insufficiency. In many cases, glucocorticoid requirements become unusually high because mitotane also increases steroid metabolism in the liver. Careful endocrine monitoring is therefore extremely important during therapy. Now let's review why the other options are incorrect. Metyrapone is a steroidogenesis inhibitor that blocks 11-beta-hydroxylase and is mainly used to reduce cortisol production in Cushing's syndrome. It is not an adrenoliptic drug. Mifepristone is a glucocorticoid receptor antagonist. It blocks cortisol action at tissue receptors, but does not destroy adrenal cortical cells. Etimidet is an intravenous anesthetic that can rapidly inhibit steroid synthesis in severe hypercortisolism, especially during emergencies. It is not used as long-term adjuvant therapy for adrenocortical carcinoma. Mitotane is unique because it directly damages adrenal cortical tissue while suppressing steroidogenesis. That is why it plays such an important role in advanced or high-risk adrenocortical carcinoma management. This case also highlights an important clinical principle. Rapid virilization and markedly elevated adrenal androgen levels should always raise concern for adrenal malignancy rather than a benign endocrine disorder. This patient is experiencing secondary adrenal insufficiency caused by suppression of the hypothalamic-Pituitary-Adrenal axis, also known as the HPA axis. The key clue is the history of chronic high-dose prednisone therapy followed by abrupt discontinuation. Prednisone is a synthetic glucocorticoid that mimics the effects of cortisol. When patients take glucocorticoids for a prolonged period, the brain senses high steroid levels and reduces natural hormone production through negative feedback. Normally, the hypothalamus releases corticotropin-releasing hormone, which stimulates the pituitary gland to release adrenocorticotropic hormone. Adrenocorticotropic hormone then stimulates the adrenal cortex to produce cortisol. But during chronic prednisone therapy, the hypothalamus and pituitary essentially shut down this pathway because the body already detects abundant glucocorticoid activity from the medication. Over time, adrenocorticotropic hormone secretion becomes suppressed. Without regular adrenocorticotropic hormone stimulation, the adrenal cortex gradually becomes less active and may even undergo partial atrophy, especially in the cortisol-producing zona fasciculata. As long as the patient continues taking prednisone, the body still receives glucocorticoid effects from the medication. The problem occurs when the steroid is stopped suddenly. The suppressed hypothalamic-pituitary-adrenal axis cannot recover immediately, so the adrenal glands fail to produce adequate cortisol during the transition period. This creates acute secondary adrenal insufficiency. The patient then develops symptoms such as extreme fatigue, nausea, weakness, and postural hypotension because cortisol is essential for maintaining energy balance, vascular tone, and stress responses. Laboratory testing confirms low cortisol levels. An important detail in this case is that mineralocorticoid function remains intact. That finding strongly supports secondary rather than primary adrenal insufficiency. Aldosterone production mainly depends on the renin-angiotensin-aldosterone system, or renin-angiotensin-aldosterone system, rather than adrenocorticotropic hormone stimulation. Because the zona glomerulosa remains functional, patients with secondary adrenal insufficiency usually do not develop severe hyperkalemia or salt wasting. Now let's review why the other choices are incorrect. Autoimmune destruction of the zona glomerulosa occurs in primary adrenal insufficiency, such as Addison's disease, where both cortisol and aldosterone production become impaired. Hemorrhagic infarction of the adrenal cortex can cause acute primary adrenal failure, often during severe sepsis or trauma. Ectopic corticotropin-releasing hormone secretion would actually increase adrenocorticotropic hormone and cortisol production, leading to hypercortisolism rather than adrenal insufficiency. The major teaching point in this case is that chronic glucocorticoid therapy must never be stopped abruptly after long-term use. Patients usually require gradual tapering to allow the hypothalamic-pituitary-adrenal axis time to recover and resume normal cortisol production. So, the primary mechanism here is hypothalamic-pituitary-adrenal axis suppression caused by chronic exogenous glucocorticoid exposure, making answer C the correct choice. This patient has Cushing's disease and is being treated with a medication that improves hyperglycemia and metabolic complications, but is difficult to monitor using laboratory values. The correct answer is mifepristone. Mifepristone is a glucocorticoid receptor antagonist. Instead of lowering cortisol production directly, it blocks cortisol from binding to glucocorticoid receptors in body tissues. In simple terms, cortisol may still be circulating in the bloodstream, but its effects on target organs become reduced. This mechanism is especially helpful in patients with severe metabolic complications of Cushing's syndrome. One major benefit is improvement in hyperglycemia. Excess cortisol normally increases glucose production and reduces insulin sensitivity, often causing diabetes or severe blood sugar elevation. By blocking cortisol's action at the receptor level, mifepristone can rapidly improve glucose control and reverse many metabolic manifestations of hypercortisolism. Patients may also experience improvements in weight gain, fatigue, and overall metabolic function. However, this medication creates a unique monitoring challenge. Most therapies for Cushing's syndrome are monitored using cortisol measurements. But with mifepristone, cortisol levels often remain elevated because the drug does not suppress cortisol synthesis. In fact, cortisol concentrations may even increase during treatment because feedback regulation becomes disrupted. This means physicians cannot reliably use serum cortisol or urinary cortisol levels to determine whether the medication is working properly. There are essentially no reliable biochemical markers for titrating therapy. Instead, doctors must monitor the patient clinically by watching symptoms, blood pressure, glucose control, potassium levels, and signs of adrenal insufficiency. That is exactly the clue highlighted in this question. Now let's review why the other options are incorrect. Mitotane is an adrenalytic medication mainly used in adrenocortical carcinoma. It suppresses adrenal cortical function and usually requires glucocorticoid replacement therapy. Ketoconazole inhibits steroidogenesis enzymes and directly lowers cortisol synthesis. Because cortisol levels decline during treatment, biochemical monitoring is possible. Pasireotide is a somatostatin analog that suppresses adrenocorticotropic hormone secretion from pituitary corticotroph tumors in Cushing's disease. Adrenocorticotropic hormone and cortisol levels can still be followed during treatment. Mifepristone is different because it blocks the receptor rather than reducing hormone production itself. That distinction explains why metabolic symptoms improve while cortisol measurements become unreliable for monitoring treatment response. The major lesson here is understanding the difference between hormone synthesis inhibition and receptor blockade. Mifepristone does not lower cortisol levels. It prevents cortisol from exerting its effects on tissues, making clinical monitoring far more important than laboratory cortisol measurements. This 12-year-old boy has a classic presentation of 11-beta-hydroxylase deficiency, which is a form of congenital adrenal hyperplasia, or CAH. The correct answer is B. Several clues in this case point directly toward this diagnosis. First, the patient has hypertension. Most forms of congenital adrenal hyperplasia cause salt wasting and low blood pressure, but 11-beta-hydroxylase deficiency is different because it leads to accumulation of 11-deoxycorticosterone, also called DOC. 11-deoxycorticosterone has strong mineralocorticoid activity. Even though it is technically a steroid precursor, it acts similarly to aldosterone by causing sodium and water retention. As blood volume expands, hypertension develops. The elevated blood pressure suppresses renin release from the kidneys, which explains the low renin levels seen in this patient. The second major clue is early puberty and hyperandrogenism. Because cortisol synthesis is impaired, the hypothalamic-pituitary-adrenal axis loses negative feedback control. Adrenocorticotropic hormone secretion rises in an attempt to stimulate the adrenal cortex. As adrenal stimulation increases, steroid precursors accumulate and become shunted into androgen synthesis pathways. This excessive androgen production causes precocious puberty, rapid growth, acne, and other signs of androgen excess. The laboratory findings complete the picture. Low cortisol levels indicate impaired glucocorticoid synthesis. At the same time, elevated 11-deoxycorticosterone strongly suggests blockage at the 11-beta-hydroxylase step of steroid production. Now let's review why the other options are incorrect. 21-hydroxylase deficiency is the most common form of congenital adrenal hyperplasia, but it usually causes salt wasting, hypotension, and hyperkalemia rather than hypertension. 11-deoxycorticosterone does not accumulate significantly in that condition. 3-beta-hydroxysteroid dehydrogenase deficiency affects multiple steroid pathways and often causes salt wasting with ambiguous genitalia in both sexes. It is not classically associated with 11-deoxycorticosterone-driven hypertension. 17-alpha-hydroxylase deficiency can cause hypertension because of 11-deoxycorticosterone accumulation, but those patients usually have decreased sex steroid production and sexual infantilism, not hyperandrogenism or early puberty. That distinction is extremely important. Both 11-beta-hydroxylase deficiency and 17-alpha-hydroxylase deficiency can produce hypertension, but their androgen profiles are opposite. 11-beta-hydroxylase deficiency causes androgen excess. 17-alpha-hydroxylase deficiency causes androgen deficiency. So, the combination of hypertension, low renin, elevated 11-deoxycorticosterone, low cortisol, and precocious puberty clearly identifies 11-beta-hydroxylase deficiency as the correct diagnosis. This case is a great example of how specific steroid precursors can help pinpoint the exact enzyme defect in congenital adrenal hyperplasia. This patient has several major clues pointing toward adrenocortical carcinoma, also known as ACC. First, he has Li-Fraumeni syndrome, which is strongly associated with TP53 mutations. TP53 is a critical tumor suppressor gene that normally helps control cell growth and repair damaged DNA. When TP53 is mutated, cells can divide uncontrollably and become malignant. Patients with Li-Fraumeni syndrome are therefore at increased risk for several aggressive cancers, including adrenocortical carcinoma. The rapidly growing abdominal mass is another important warning sign. Benign adrenal adenomas are usually small and slow-growing, but adrenocortical carcinoma often enlarges quickly and becomes invasive. The mixed endocrine syndromes are also highly characteristic of functional adrenal cortical malignancy. Many adrenocortical carcinoma tumors produce multiple adrenal hormones at the same time. Patients may develop features of Cushing's syndrome together with hyperandrogenism or virilization. Laboratory testing may reveal elevated cortisol, DHEAS, or abnormal steroid precursors such as 11-deoxycortisol. Once advanced disease is confirmed, systemic therapy becomes extremely important because adrenocortical carcinoma has a high risk of metastasis and recurrence. The standard first-line chemotherapy regimen for advanced adrenocortical carcinoma is EDPM, making answer C correct. EDPM stands for etoposide, doxorubicin, cisplatin, plus mitotane. Each component targets the tumor differently. Etoposide interferes with DNA replication by inhibiting topoisomerase II. Doxorubicin damages DNA and disrupts rapidly dividing cancer cells. Cisplatin creates DNA crosslinks that trigger tumor cell death. Mitotane is especially important because it is an adrenolipid drug that selectively damages adrenal cortical tissue. In addition to suppressing tumor growth, mitotane also reduces excess steroid hormone production. Because mitotane suppresses adrenal function so strongly, patients often require high-dose glucocorticoid replacement therapy during treatment. Now let's review why the other options are incorrect. Doxorubicin, bleomycin, and vinblastine are used in certain other malignancies, but they are not the standard regimen for adrenocortical carcinoma. Cisplatin and etoposide alone may have some activity, but they are less effective than the full etoposide, doxorubicin, cisplatin, plus mitotane combination. Multi-tyrosine kinase inhibitors are being studied in various cancers, but they are not currently considered standard first-line therapy for advanced adrenocortical carcinoma. The key concept in this case is recognizing the aggressive biology of adrenocortical carcinoma. Rapid tumor growth, mixed endocrine syndromes, and TP53-associated cancer syndromes strongly suggest adrenal cortical malignancy. For advanced disease, etoposide, doxorubicin, cisplatin, plus mitotane remains the established first-line systemic treatment because it combines broad cytotoxic chemotherapy with the adrenal-specific effects of mitotane.